So this is my pre-op, and a little history here. This is an older dentist, and the patient is his wife. And the older dentist is retired, but he did this work some years ago, and now his wife is in my chair. And so I told him, the lesion is not apical so much. The lesion is much more asymmetrical. That tends to suggest a lateral canal or maybe a deviation of the post along the long axis of the true canal. He had done the gutta percha, and he had done all the restorative work, and it was quite nice. And they were very happy with the aesthetics. And so what I said was, look, the post is not following the long axis, and remember to move the cone. We just talked about that in head scratchers for Hideki. His case, we said move the cone horizontally up to 30 degrees. You don't have to go to 30, but get it off axis so you get a completely different look. We also traced the fistula. There was a long chronic problem, and so there was a sinus tract, and we traced it with gutta percha. But this is the other angle that I want you to get. So as you start to move the cone, what looks like maybe a little deviation is now a big deviation, and that suggests the etiology of the Leo on the lateral root is related to a perf, post-perf. So you can see the importance of angulation, can't you? Now, what I did is most of the retreatment for me, as it came down over the years, is not the technical stuff and all the things you do. It's talking to people and being very clear with them. So he was in the operatory with his wife, and we're having a consultation. And so what I'm telling him is, I'm not so certain I can get to that surgically. Well, first I said, ideally, let's take the crown off. Let's get the post out. Let's retreat the case. Now, I want to talk about retreating this gutta percha because you're thinking, there's not so much pathology. The bone's quite good around. I might even see a PDL. So there's the world that is, and there's the world you see, and they're very different. You'll see that. Remember this gutta percha, and we'll show it in a photograph. So I wanted to disassemble the tooth, and the dentist said, no. Okay, so one arm is now tied behind my back. I can't force people to do stuff. So he said, I'd like you to try to fix it. And I said, you mean surgically? Yes, he was very upset about surgery, but yes, we could do surgery because, non-surgical disassembly isn't surgery. So I would have thought he would have liked that. But see, I think because he's retired, he's wondering who's the new dentist and who's going to put the crown on and all that stuff. So I said, okay, we can flap it, but there's a good chance if it's directly palatal or mesial palatal or distal palatal, I'm not going to be able to technically approach the post to bevel it back inside the root to make a little slot preparation for my retro material, my lateral repair material. We just talked about root repair material, okay? So there are some similarities of the Hideki case. So I made a full thickness intercircular flap. I made a combo flap. Here it's attached gingival flap so we don't touch the margins and we won't have recession. And I'm taking out a big wad of granulomatous tissue from that large lesion that you see over here. So that's not just an empty space. It's got granulation tissue. And once I get that out, I skip some slides for just expediency, but I couldn't get to the post. I couldn't even see the post. So I could see the whole surface of the root. You can see part of it right in here. And with this out and a little bit more curetting, you can see that whole thing, but I couldn't see the post. I couldn't even get a Zini mirror. That's a little tiny retrograde mirror to stick around the back of the root. And I could get it in there, but I wasn't going to be able to do it. I didn't have the skill. So what we did is had to stop everything, suture. And he wondered why we were suturing. We hadn't made the repair. And I said, there's only one thing left to do. What's that? What's that? Well, we could extract the tooth. I came here to save the tooth. Okay. But I said, if I can't get to it, the lesion's not going to go away and you're going to have a chronic infection. So if we're going to extract the tooth, the good news is, what if I could repair the tooth and replant it? And he thought I was crazy at that point. He said, this is remarkable because I've never heard of this. taking her tooth out, intentionally extracting it, and you're going to repair it and replant it. And I said, well, either go back to the oral surgeon and have the tooth extracted, or I can extract it here. And anyway, that's what we decided to do. So with the tooth out on the bench, soaked in
I had a question. Had you done this before when you decided to try this out?
In this era, this is probably like my 10th one.
Okay.
That's a good question. You're not so confident on your first one or your second one. I ended up doing in my career about 50 intentional replants, and I kept probably over 40 of them, and I mean 40 long term. And I didn't get all the inflammatory resorption, the replacement resorption. Replacement resorption means slowly eating away at the root, as you know. That means the tooth will slowly be lost. It could ankylose, so when you hit it, it sounds like you're hitting a hammer on an anvil. That's ankylosis. So you can get ankylosis, you can get reparative resorption, and you can get inflammatory. Inflammatory resorption, the root is eaten away rapidly in just months, few weeks to a few months, the tooth is gone. So here it is on the bench, Hank's salt solution. You can see it in here. And what do you see here? You're seeing what's left of what I didn't get out over here. So this came out of the osseous part. This is attached to the root. So with that in mind, I'll show you this is the lingual view. It's a little off axis. This is the facial view. And I want to bring your attention to this. I just beveled the root, and I beveled the root angled like that because that's the part of the root that faced the lesion. Remember, the lesion was lateral. So if you look carefully, does everybody raise your hands? I can see every one of you through AI. Do you see the black delineated mark around the pink gutta percha? That's leakage. That is stuff and breakdown products, okay? So it wasn't sealed apically. Remember the film I said? I said, look, it looks pretty good, right? So a lot of you look at those films and you go, gee, I don't know why they're hurting. I tap on the tooth, it's fine. The x-ray shows intact PDL, but a lot of times it isn't what you see. Remember, there's the world you see and there's the world that is, and they're not the same. Not always. And then here is just flat out straight lingual. So this was lingual, but it was a little bit off axis. Now, you don't want to scrape roots. You don't want to curette roots. But if you're going to get to the post, you at least have to curette away the granulomatous tissue to expose the post so I can bevel the post back into the root, okay? Back into the root. And then I can make a repair. So I'm going to have to repair here. I have to put a retrograde up here, and then I'm going to have to do something with that right there. So don't be scraping the roots, but you can remove granulation tissue if you need to get to the post in this case. Remember your assistant the whole extra oral time. She's dripping continuous flow Hank's salt solution. You got to keep the tooth moist, wet. You got to keep the PDL fibers alive. You don't want dehydration. So the assistant is faithfully irrigating constantly while we're doing the extraoral work. All right. So the tooth is now replanted. This is immediately. You can see, if you look here, you'll see a little shadow. That's a little shadow. That's the splint. We're getting to Hideki's question. I put in, I don't know what the era, this was decades ago. So in that era, originally we used amalgam, and then we went to EBA, ethyl benzoic acid, and then we went to something like maybe the bioceramic putty. We said putty is good. So there's been an evolution over time of better and better and better materials. Biodentine is also terrific for this. And these two can be thought of as very similar. They're both bioceramic materials. They're both putty type stuff. They have body. You can pack them and move material. We showed that Hideki using, as he called it, the endosequence root repair material. That's what he used in the palatal canal only. So in this case, we've got the apical corked, and I try to get up that canal more and more. In other continuums I've done, I have taken all the gutta percha out, but that's when the tooth is in the mouth with a rubber dam on. I am outside the mouth, so I'm trying to keep the extra oral time 5 to 10 minutes, max 5 to 10 minutes. So you don't have time to do reverse clean and filling and all that stuff. So that's a cork. And then here we have beveled the root back, the post back into the root, and I have a repair material here, as you can see, same material. And I think in that era we were using EBA. It certainly is an amalgam. These were not yet born. They didn't happen yet. They weren't around. So you're saying, great. So this is at about, we didn't get any photos right then, but I just want you to see the splint. This is my splint, and Hideki asked me now exactly, we want a soft splint. We want a splint that allows movement. We want the tooth to be able to move a little bit so the Sharpie's fibers can find each other, the Sharpie fibers on the osseous side and the Sharpie's fibers attached to the root. And fascinating studies in the textbook right over there, Andreasen, they actually find each other, and that eliminates a lot of times resorptions and ankylosis. So what I didn't like what I did here is I got a little close to the gums, gingiva, if you like. So I would have, in today's world, I would have just done it like that. I would have followed notice the contour of the tooth. So I would have brought this up like that to follow the contour of that tooth. And I would stay a little bit away from the gingiva. So while we're trying to get a reattachment, we don't have debris, food debris, plaque. We got to have that patient use a soft bristle brush. It's very gentle massaging to keep this as clean as possible. This is a little bit, this could be even 10 days later. You can see I had to suture. You're going, well, where's the suture? We don't see the suture because we made a full thickness flap. We probably got a little recession here. That could be a critique. The patient did not have a high lip line, and all this was discussed. Because if you get a lot of, not a lot, but if you get a little bit more recession and she has a high lip line, he and she will not be happy, especially the dentist. So you got to explain to them, even if you lay a flap and did nothing and put it back, you're going to get about a 1/2 to 1 millimeter of recession. It's expected. Okay, so that's the splint. Now, what was the material? Hideki, I made a mistake in my answer. In that era, we used the first generation of a composite resin. This was the late 60s, early 70s. This was a miracle. This came out to replace amalgam, silver fillings. So I knew that if I didn't cover all this, and if I didn't cover all this, I just needed interproximal. I only need a splint on for 7 to 10 days, max 2 weeks. And then it's gone. You got to take it out with a tapered Fisher burr very carefully, start cutting in here, then you can use some perio instrument like a Gracie and clean the root and get it back to normal. Get the tooth back to normal. So there's our post-op. And here we are pretty much down the road, and you can see how that bones come in. You can see a tremendous osseous repair as compared to the lateral pathology. And I'd like to say a few things about splints, soft splints. I've already explained why. I explained that it was adaptic. I think I said to Hideki you could use Ribond. You could use any kind of a new generation, way beyond adaptic, resin composites. And there's whole things Ribond, you have to lay some fibers over 3 teeth. They're like little strips of polyethylene, and you cut them and you lay them and measure them before. Then you begin to prepare the surface with acid etch, and you got to acid etch a little bit, acid etch a little bit, and acid etch a little here. And that acid etch and that material will bond with your Ribond polyethylene strips, and you can have a very nice result aesthetically. It doesn't have to be powerful. There's no occlusal loading on these things, and allow the tooth to move a little bit and function. Now you might want to add something because there was some other stuff, Copac, whatever. Just read it.
I actually just was wondering because he said he couldn't find detailed information about it in Andreasen's textbook, and he asked you if you had some references, which when you responded to this, you said you had some time restraints, but try maybe looking at the positional statement from the AAE, pocket dentistry, etc. Did you want to elaborate on what on this part of the question?
So I came over here to get my book because I have a library at home and a library here. This is the Andreasen book, and it's got a lot of really wonderful pictures and stuff. There was nothing about a soft splint. There was nothing in the chapters. There was nothing about, there wasn't even in the chapters, there wasn't even a word called intentional replant. It was all false teeth and stuff, like real trauma. But I went to the index back behind, I looked up soft splint, and you can go, there's a few pages he'll refer you back to, and it's a description of maybe a paragraph or a few words. And I could see why Hideki would say he didn't find much. But general dentists know how to bond. Endodontists are learning how to bond, and my impressions are the younger endodontists know how to bond perfectly. But this is all about adhesion dentistry using a composite resin, and I mentioned Ribond. That was good. He mentioned Duraseal. Duraseal is almost exactly like Adaptic. Mm-hmm. We use the word acrylic and resin almost interchangeably as dentists, but Duraseal is an acrylic resin, and my Adaptic that I used was a composite resin. So I'm not going to go into chemistry and bonding materials. That's over my pay grade, but all dentists that do general dentistry know this perfectly. But you can Google, but those are the materials. I would say those are the best materials. Adaptic's gone. It's been replaced by 6th and 7th generation materials. So Adaptic, remember, it was a composite resin. Well, if you look at composite resins today, that's what we're using routinely to do all kinds of aesthetic dentistry, durability, ease of work, and aesthetically pleasing.